As ever, a huge honor and pleasure to be here to speak to this really very special audience who are at least the bravest selection of people I know for the most part. So this is a short description of what trials and the types of treatment you are going to get in trials is like. Please ask any questions at any time. It's not a test. It's not you don't have to pass an exam consequent on this. So cancer this is a list of the available cancer treatment options. From surgery, transplant, chemotherapy. There are a few things missing here, but these are really currently the things that if you have treatment as a cancer patient you might get. The treatments that are open to bile duct cancer cholangio patients are primarily immunotherapy, radiation therapy, targeted therapies, chemotherapy, surgery. Not really hormones or transplants as yet. And I'm going to concentrate on the immunotherapy and the targeted therapy bit of it. I think other people will speak to the other things in a bit. But what are clinical studies? So just an intro into this really. And we speak commonly of three types, phase 1, 2, and 3. So phase 1 studies is the guinea pig situation. So you are opting to have a treatment that's not really been proven before previously, in many cases previously only given to mice. And you are the guinea pig. You are the person who's going to test whether it's safe primarily, and what is the safe dose, and almost an afterthought whether it's any good or not. The next, and if it is safe, and of course we know that some of these things are not safe, but if it is safe, the next thing you'd do is you'd go on to the phase 2 trial. And the primary intention of that is to see whether something works. And the numbers reflect that. So in a phase 1 trial, you only have a few people in a phase 1 trial, just making sure that those people do not suffer too much in the way of side effects. And the phase 2 trial, you have more because you need more people to determine whether something works. And so, and these phase 2 trials can be single arm or randomized. I'll come on to the randomization issue in a second. And then really if some kind of treatment gets past those points, in other words, it appears to work, normally there is a thing called the phase 3 trial, and that's normally a randomized trial where some people have the standard treatment and some people have the experimental treatment. And the intention of that is to work out really whether it's worth it and how good it is compared to what people normally receive. The common theme running through all of these studies increasingly is what we call the translational endpoint. So it's no longer good enough, and certainly not good enough to get a grant to run one of these things, to just use the drug and test it on somebody and see whether it works or not. You have to do lots of tests around where the treatment is working, how the treatment is working, and that means lots of samples, blood samples, tumor samples, all sorts of samples to see how it's working and if necessary, change tack and do something else if you don't think it's working, work out why it's not working. So the translational endpoint is now becoming really a central part of all of these studies as well, and indeed some of the endpoints, some of the outcomes really do depend a lot on it. These are bigger studies. These are 200 plus patient studies. So what about some of the new things that we've been coming into? Well, immunotherapy has been around now, I guess, about 5 or 6 years, and constitutes one of the main treatments for cholangio patients. And I'll just run through what immunotherapy is. It's essentially antibody that is directed against your immune cells. So these cells here these cells here are CD8 T cells. These are important cells because these are the guys that actually attack and kill the cancer cell. And quite often in a cancer, the cancer cell has evaded the attentions of these guys by developing new mutations, new alterations within the way that they're recognized. You're recognized through all these little connectors here. And some of those cancer cells are really actually extremely good at evading that. Indeed, arguably, they've only grown into a cancer because they have evaded it. Now, the intention of immunotherapy is to unlock that lock that these cells have made, and they're essentially antibodies. So we have antibodies running around our system the whole time, and these are engineered to target these particular interactions between these cells to try and trigger your own immune system to fight the cancer. Surely the best way of doing it. So the example I've shown here is what we call a bispecific. So one arm of this antibody targets one type of immune target, and the other arm targets another type of immune target. These bispecific things are the latest things. They've been around maybe slightly less long, 2 or 3 years, and they are thought to be much more effective than mixing up combinations of those two things. So really, the intention here is to get your own immune system off its bottom and working again. And some of these immunotherapies are more effective than others. And we're still in the process of working out exactly which ones are best. So this has been a great advance. So immunotherapy is now, as I say, part of the standard of care. The other name for them is checkpoint inhibitors because they unlock the checkpoint, they unlock the immune checkpoint. Oops. The other main treatment we use in cholangio is genomic treatments. Cancer is, for the most part, a genetic disease. So this is what normally happens in your cell. You have something circulating in your bloodstream or around where the cell is. It hits a receptor on the surface of the cell and stimulates your nucleus, your DNA, to do its normal business. That's how it normally works. In cancer, you have an abnormality of the, well, for instance, you can get abnormalities all along this really, but for instance, you have an abnormality in the receptor. And this is how it happens. So instead of having 2 chromosomes like this, one next to the other, you get a switch. You get a switch. So instead of getting 2 perfectly functioning chromosomes, you get 2. They sort of flip across. They cross over, and you have 2 abnormal bits of chromosome. And abnormal bits of chromosome, for the most part, get corrected, but sometimes can persist and start the cancerous process. And so instead of your normal stimulation of the DNA and nucleus, you have really extremely abnormal stimulation, hyperstimulation of the nucleus that makes your cells grow out of control, and that's what we know as cancer. And the treatments that we have, targeted treatments, block this process. They are able to block this hyperstimulation, and that's the whole intention here. What about randomization? So randomization, and that's an essential part of a lot of these studies. Randomization is where you have a clinical study examining a treatment, and some of the people get the experimental treatment and some of the people get the standard treatment. And the reason we need this is to be able to compare the standard treatment to the experimental treatment. And you may well ask, well, surely there are other ways of doing it. There are other very decent ways of doing this. And actually, this is still the best way of doing it. And we have to do it because if, for instance, a while back, doctors were allowed to decide which arm you went into, and they were completely untrustworthy. They could not be trusted to do this, and the results were a terrible mess, and it was pointless doing a study. So the only thing you can do is take it away from doctors, make it a doctor-free procedure, and randomize the patient completely by chance between one treatment and the other. And that is still the best way of doing it. These days, there's a lot of talk of what we call synthetic control arms, and that's, so instead of giving the, having patients actually receive the standard bit, you have terribly clever AI models that simulate what these patients would do and would be like. That's a nice idea, but I think an extremely difficult one. I'll show why that is in a second. This is just an example of something that we have coming up, in fact, led by Julien Edeline, who's in the front here. And this is a study that we have coming up, hopefully in the next couple of months in the UK. It's already open in France, testing chemotherapy against a new immunotherapy agent. And this is and why do we need these randomized studies? Well, we need a high level of evidence in order to get these things funded. This is a slide from the NICE evaluation. So NICE is the committee that decides whether we can afford treatments. This is a slide from the recent evaluation of zanidatamab, which was September last year, and has last week, I think, or the week before, been actually now formally improved. And despite all the evidence that goes into these meetings, the company spends the best part of a year preparing the documentation to go into NICE to do this. Despite all of that, they are pretty brutal. Robustness of clinical evidence, unknown. Survival extrapolations, medium. They are pretty hard customers to try and satisfy. And really, this emphasizes I'm afraid, still the need for high-quality randomized data. Now, I know I've randomized many people into clinical studies, and patients hate being randomized. It's completely understandable, but they really hate it, and they even hate even more being on the control arm. But currently, I'm afraid that is still the only way of doing it. Very interested to hear comments from my colleagues in the room. So, and this is the other reason, this is one of the reasons why using what we call a synthetic database is not very good. So what the company did for the zanidatamab, this is still the zanidatamab application, what they did was they got a number of patients from, in fact, a US database called Flatiron, to try and extract people who would be similar to the people treated with zanidatamab. So was it possible to get a number of people who you could use instead of a randomized arm, for instance? And so they took 27,000 people from this database, of whom 290 had a type of cancer like that which was tested in the Zani studies, and of those, only 12 fitted the criteria. So you've gone down from 27,000 to 12. So it really is difficult duplicating synthetic control arms. And in some ways, if you look at this process, randomization is way the easier thing to do. So let me take you through some of those things that I've tried to explain to you by describing our current study. Actually, it's got this is the ABC10 study, the Saphir ABC10 study, which we're running with France and Belgium. This describes the UK component. It's already slightly inaccurate. I'll explain why. And it's people with advanced disease. And they have, it's 2 bits, it's composed of 2 bits. It's composed of the testing, so you test for a molecular abnormality, so you test for one of those genes that have gone wrong that I described earlier. And while we're doing that testing, because it's quite complicated, you have 4 lots of the chemotherapy and the immunotherapy treatment that is the standard treatment. If you do happen to have one of these alterations, and about 1 in 3 people do, one of these alterations down here, you are randomized, that dreadful R word. You're randomized between the new stuff, or relatively new stuff, the targeted treatment, or simply continuing with your standard of care. And that is the only way that we're going to be able to bring all these potentially really good drugs up into what we call first-line treatment, right up as early as possible. That's the only way we're going to be able to do that. It's told me. So this is what we're doing. Once the standard of care treatment doesn't work, you can then cross over. So this study, it's a question of when you get the targeted treatment rather than whether you get the targeted treatment. And we've done really well. In fact, we're going to screen 500 patients altogether. But the other thing that happens as a result of this is that you discover new things. And so this is the standard study on the left here I've just described to you, but consequent on doing all that testing and seeing all these patients, we come up with new studies. So in addition to the IDH1 gene, which was on the original list, we've found that it's actually the sort of poor sister I've always described it of the IDH1 is the IDH2. And we've managed to persuade Servier, I think they're here today, anyway, Servier, the company who make this drug vorasidenib for IDH2, to run an IDH2 study. So that's an instant positive spin-off. Similar things have happened, so we're still in discussion with this company about a drug that targets BAP1. Julien is leading a study looking at RAS. There are discussions about a radiation study, and this is the severe study that I just described earlier on the thing. So you start off a sort of process like this, and you should be able to get lots of spin-offs, and hopefully that's what's happened. So in summary, clinical trials and all the things that are associated with clinical trials like randomization are really essential for still, I'm afraid, for demonstrating efficacy and most importantly convincing the reimbursement bodies, in our case NICE, to fund these often quite expensive treatments. Early access to effective therapies, you heard it earlier in fact, is critical, and being able to travel and randomization are complicating factors in this process. And the translational components, in other words, doing the testing, making sure you make the most of the testing, is absolutely essential. All the people that helped me, thanks very much for your attention.